Welcome to Find Your Shape, a podcast by Lewisburg Plastic Surgery featuring Dr. Alexander Moya, the expert in body contouring after weight loss and inventor of the Corset Body Lift. Hi, my name is Brittany, and I will be your host. In each episode of this show, Dr. Moya and I will discuss the complex world of body contouring after weight loss. Our goal, as with everything we do here at Lewisburg Plastic Surgery, is to provide you with the educational resources you need to make the best decision for your personal situation. You've lost the weight, now let's find your shape. Hello, Dr. Moya.
Well, hello, Brittany.
Fancy seeing you here.
Yes, that is very strange. Actually, looking forward to it every single time.
I know. Okay, so today I want to just briefly ask a little bit about your preference for pain management post-operatively. What's your go-to?
Great question. So if it's something where I feel that pain levels are going to be low, we just do a generic oxycodone, a generic narcotic, a short-acting narcotic, and we ask patients to take some Advil. I definitely believe in the anti-inflammatory as the primary treatment of pain because it treats the inflammatory component of it, the actual trauma of surgery. And then sometimes patients can take Tylenol mixed in there as well. Now, as you know, most of my surgeries are pretty big.
Right.
So when you start talking bigger body lifts, you start talking combined procedures, then I like to add another prescription. It's a long-acting narcotic with the short-acting narcotic. What does that mean? It's an extended release narcotic. For me, again, my go-to would be, let's say, a generic oxycodone. So now we're talking extended release oxycodone. Why do we do that? Well, there are many studies out there when it comes to pain that have shown that an extended release formulation can really help decrease overall pain because your body now is not requiring a pain pill every 4 hours and it's not going from 0 to 10, if 10 is the top number.
So frequently throughout the day.
Correct. And then what happens is the moment your brain feels a 10, it gets sensitized to that. And it's hard to desensitize it. So I'm very much active in trying to prevent patients even experiencing that level. And the best thing I found is you add in an extended release medication that's every 12 hours. It's a slow release. It's being broken down slowly. What's nice about that is it doesn't usually make you sick to your stomach. And it doesn't usually make you confused. So that's nice. A nice corollary to why we use the extended releases. So once you have that on board, and all of a sudden you start having pain, let's say instead of starting at 5 and going to 10, you're starting at 0 or 1 and going to 5. And then when that happens, then you can take your short-acting pain pill if you need it, and it keeps you in much better pain control. You're not going to require that short-acting pain pill as often.
And it's safe to take both of them.
Absolutely. Patients always ask, am I going to overdose now? Am I taking too much narcotic? No. If you're still having pain, that means you're not getting enough. That's the best way to explain it. So an extended release medication is not given for pain. It's given at a specific time period in the post-op recovery. So meaning whenever we're done with surgery, I usually recommend to patients, okay, you're going to start this extended release narcotic at 7 o'clock tonight, 8 o'clock tonight, 9 o'clock tonight. Give them a very specific game plan. And that means that at 7 o'clock or 8 o'clock in the morning, they'll take the next dose. So we'll do that for a few days. It's in their system. Then they do have the short-acting pain pill to take as needed, which they're going to take less. And then, of course, we're going to throw in the anti-inflammatory, the Advil, the Motrin. And then if patients need it, they say, I'd prefer not to have as much narcotic, then we're going to throw in a Tylenol. In between the doses of the Motrin, they can take the Tylenol, and then the requirement for narcotics starts to drop. So we've been really focusing on post-op pain for a long time. We found that this combination, and then of course, just like surgery, I'm going to customize it for every patient, post-op experience. Right. Because everybody's a little bit different. So I'll figure that out within the first 12 to 24 hours. We kind of figure out what they need best. But those are my go-to. So I do believe in extended releases when it comes to better pain control overall for some of my bigger procedures.
Okay. And again, about safety measures, the Oxycontin and oxycodone are good because it's a plain medication. It's not combined with anything like a Percocet or a Vicodin where you have to worry about adding in the Tylenol or dosing or, your daily maximum dose of anything.
Correct. That's why we give that separate. So it's nice to do a medication that's plain. And then we can adjust the other ones as needed.
Right.
Otherwise, if you're taking oxycodone one every 4 hours and let's say a Percocet and you're taking one every 4 hours, you have the 350 milligrams of Tylenol in it, you can overdose.
Right.
So I always like to do it separately, and then we do the additional Tylenol as a separate medication.
Yeah.
Now, if a patient is allergic to an oxycodone, we do have other extended releases, like there's morphine. Morphine comes in an extended release form. So we do have some other options, but I do tend to prefer to mix those combinations for the best pain control. And I have found in my own personal practice experience, I've been doing that for now 22 years using extended releases.
Wow.
And before that, it was a big difference when I switched over early on, the difference in the pain levels for the same procedure for patients.
Right.
And that's why we continue.
And how would they come off of some of the narcotic pain medications? Is it okay if they just abruptly stop? Do you taper things? How does that work?
I usually have them taper. So the first thing I'll have them taper off is the extended release. So that if some patients, depending on their body frame, their size, I might start them on 2 pills every 12 hours. Then I'll tell them to go down to 1 pill maybe at night or 1 pill in the morning. And then they go to 1 pill twice a day, and then they go 1 pill once a day, and then they're off.
Okay.
But we guide them through that. And we tell them we give them an idea what's the best way. And then they have the oxycodone to take as needed. And usually that'll be the next thing that they'll go off. And it's nice, then they can stay on the Advil if they like, and they can stay on some Tylenol if they like. So they have a nice transition of pain meds as the days go by, as they're healing.
Right. So I feel like it would be good for the patients who are planning surgery to, if they've had surgery in the past, look back to see what they've been prescribed for pain before, to see if it's something that's been helpful for them, if they've had any weird side effects, anything like that, just so that we are fully prepared to prescribe things properly.
Absolutely, because those are all the questions we're going to ask them. We're going to get really deep into figuring out what's going to work for them,
right, and
what hasn't worked in the past.
Right.
And then with that, we can come up with the right game plan for a good post-op regimen.
Yeah, and when we do ask those questions, they're like, yeah, I can't remember, but I had it for when I had my gallbladder out. And, it's good to have that information up front.
Absolutely. It definitely is helpful for the game plan.
Right. What about any type of long-acting injectable pain medications? We get that a question every now and then.
Again, great question. A lot of my procedures we do in the operation give pain control first off. So what we're talking about is obviously taking something by mouth, orally. But in order to decrease pain in the immediate post-op period, pretty much all my procedures, I do use long-acting Novocaine. It's called Marcaine. And I'll inject it in the areas that I know are very sensitive, that have more nerve endings. For instance, any abdominal muscles that we tighten, I'll inject it in the abdominal wall. That really blunts that type of pain. Patients are pretty comfortable. The first 12 hours, don't even really know we did this tummy tuck on them. I might inject it in the groins when we do a tummy tuck, or a thigh lift, for instance, to numb up those nerves. I might inject it along the underarm when we do arm lifts. And those are all areas. When we do breast lift, I inject it along the folds themselves. So I've figured out areas that these type of longer acting injectables seem to help in the post-operative period. So of course that'll always be done before the patient even wakes up. So that's on board already.
Okay.
So that's great, great question.
Yeah. Very rarely, but we do get a question on like a pain pump type of situation. And your thoughts on that? Because of the extended releases? That's a great question. If you don't do extended releases, that's one of the things that we used to have. We used to use that more in the hospital. In the hospital setting.
A PCA pump, a pain pump. But I actually got away from it before I left. When I was at the hospital working for Geisinger, a healthcare system, I used to use the pain pump, and I actually got away from it using extended releases. I had actually better pain control. So that's actually that was a very good example. I got off using that completely for my patients before I left the hospital system.
Good. Okay. I think that pretty much covers all of it. Thank you.
Great. Thank you so much.
Yeah.
That's a wrap on this episode of the podcast, brought to you by Lewisburg Plastic Surgery and Dr. Moya. Please be sure to subscribe to our show so that you never miss an episode.
And for more information on Lewisburg Plastic Surgery or the course of body lift by Dr. Moya, please visit us online at lewisburgplastic.com. We'll see you next time.